Thank you all for coming this morning. What I'm hoping to do this morning in about half an hour is to really take you through a sweep of what we know about mental health problems in children and adolescents in the global perspective. As Zulfi has just mentioned, when we think of global child health, this is not usually the topic that comes to the forefront of our imagination. When we think of global child health, it's usually nutrition, infectious diseases by far which dominate, child survival, which is a critical goal. And so when we think of children thriving, which of course is the agenda in where the direction to which child health is now going in global health, the issue of mental and developmental health is becoming increasingly visible and pertinent. So what I'm going to do is, first of all, briefly tell you what we know about the burden of these disorders. And although I'll start with the global burden of disease, as I guess most global health lectures must begin with these days, I really want to go beyond just the metrics of the burden of disease and suggest to you some of the broader impacts that these conditions have on children's lives and the lives of their families, and also bring in what I think is a very unknown aspect of mental health problems affecting children, which is the human rights aspect. I'll then briefly talk a little bit about how health systems are responding globally. And by the word global, of course, I am really restricting myself to those countries of the world that are low and middle income. The word global should imply all countries of the world, but within the context of this talk, I'm really going to be focusing on low and middle income countries. And then I will end my talk with some of the exciting opportunities in how we can address mental health problems in children, even in the least resource environments in the world, using some of the innovations that have really come from other areas of global child health. And you'll see an example as well from a program of work for children with autism as an illustration really of how that is being played out. So let me start with the burden of disease. This slide really from one of the earlier iterations of the IHME burden of disease estimates really shows you two important things. You can see on this slide for young men or boys and girls, children aged 0 to 9 years and adolescents from 10 to 19 years. For high and low and middle income countries, the high income country bars are the blue ones, the proportionate burden of disease in these age groups and genders that can be attributed to mental and substance use disorders. And the two important observations that you can see here, first of all, is the dramatic increase in the proportionate burden as children move into adolescence. This is, of course, a very important observation, which also sits very well with our knowledge that most mental disorders that you see in adulthood, for example, mood and anxiety disorders and the psychosis and substance use disorders, have their origins really before the ages of 24. So you can really see a very good consistency with that observation and this slide that the proportionate burden increases with age up into adolescence. The other important observation really here is that the proportionate burden is higher in high-income countries. Now, of course, many less informed readers of these slides would interpret this as suggesting an increased prevalence of these conditions, but of course that is not the case. What this slide is simply showing is a proportionate burden. And what this tells us is that as countries make the transition epidemiologically and demographically from countries where you have a high burden of poverty-related diseases such as infectious diseases and move into middle and high-income countries, you will see a proportionate increase in the burden of non-communicable and chronic conditions, of which mental and substance use disorders are a very leading fraction. So this also means that amongst the countries that house the largest number of children in the world, countries, for example, in South Asia and East Asia, where there is a dramatic epidemiological transition taking place, we will see over the next few years and decades a dramatic increase in the number of children who are surviving into adolescence, and therefore we would expect also a dramatic increase in the numbers of young people who are affected by these conditions. So indeed, you can see here on this slide what we are already observing in the year 2013. This is showing you a slightly different way of presenting the burden of disease, the causes of the disease burden in young girls aged 15 to 19 across 3 different groups of countries that a categorization system that we use for the Lancet Commission on Adolescent Health that was published a few months ago. And what you can see in young girls here is that mental disorders are the second leading cause of the burden of disease following chronic physical conditions. Chronic physical conditions, by the way, are predominantly in young girls in the global context, a condition like iron deficiency anemia. So they're really nutritional disorders. But following that, you will see mental disorders as another, the second major cause, and you'll also see injuries occupying quite a significant sized blob there. And of course, the leading injuries in young women is suicide. I'll return to that topic in a moment. If you look at the same sort of distribution for boys, again, chronic physical conditions will dominate here. Anemia is also very important in boys, although perhaps much less well recognized. But soon after that, the next biggest blob is injuries. Here, we're looking both at suicide, but also other kinds of injuries, road traffic injuries, for example, as well as injuries related to intentional violence. And just after injuries, you will see mental disorders occupying another important cause here. What's also perhaps not labeled in the chart itself is alcohol and drug abuse, which you will see here also emerging as a very important cause of the burden of disease in older adolescent boys. If we look further into the kind of patterns of disorders in boys and girls, on this slide, what you can see is the breakdown amongst those who have a mental or substance use disorder. What are the types of disorders that you will see in children and adolescents? On the left-hand side, the pie chart will show you children age up to 9, and the right-hand side is adolescent from 10 to 19. And this particular slide is showing you the pattern for boys. The most important observations on this slide is that in children, the leading mental health-related causes of the burden of disease are childhood behavioral disorders and, of course, developmental disorders such as intellectual disability and autism. In adolescent boys, you will see a slight change in pattern, and you'll see the emergence of mood and anxiety disorders as a very leading cause of the burden of disease alongside substance use disorders. And similarly, you can see two pie charts here for girls. Here again, you will see developmental disorders playing an important role in early childhood, although relatively a smaller fraction. Of course, this is consistent with what we know about the epidemiology of developmental disorders being relatively more common in young boys, especially certain conditions like autism. And you will also see the emergence of mood and anxiety disorders as a very important, very significant cause of the burden of disease in adolescent girls aged 10 to 19, a much smaller fraction which is attributable to substance use disorders. Now, another important aspect of the Global Burden of Disease report, and this is, I think, the last slide I have from that particular report, is to think about how behavioral factors are contributing to the overall burden of disease that you see in children and adolescents. And in this particular slide, what I'm showing you is the contribution that behavioral risk factors play to the burden of disease in adolescents aged 15 to 19. And a key part of this slide really is how these risk factors have changed in the overall contribution, the ranking between 1990 and 2013. So if you look at the extreme right, you will see the ranking of risk factors in the most recent iteration of the global burden of disease. And what's very obvious here is that behavioral risk factors leading the pack, alcohol abuse right at the top, and a little bit further down you'll also see substance abuse of other kinds, drug use, and two forms of violence, violence against children of a sexual nature and intimate partner violence appear as 4 of the 10 leading leading risk factors, but these are all behavioral risk factors. Now, beyond the metrics of disability-adjusted life years, which is what you've just seen so far, there's, in global health, rightly, we are quite concerned about the conditions that kill people. Those are often the major drivers of priorities that are set by donors and by governments. And it has to be said that we often don't think of mental health conditions as being leading causes of death in most parts of the world. This is definitely true in childhood. It would be fair to admit that in childhood, mental disorders are not a leading cause of death. However, this is not the case in adolescence. In adolescence, in fact, mental disorders are already the leading cause of death in many parts of the developing world. In this particular slide, I'm showing you the leading cause of death in young people in India, age 15 to 29, but even if we took just the adolescent age group up to 19, you will see a very similar picture. That is to say that suicide is now the second leading cause of death. Actually, this table comes from 2010. The most recent data that comes from last year, in fact, shows that suicide is now the leading cause of death in young women in India, including adolescent girls. And suicide is more or less equivalent to road traffic injuries as the leading cause of death in young boys. Now, the interesting thing about this figure from India is that actually this is also the case in other low and middle income countries, such as Nepal, for example, where suicide overtook maternal mortality as the leading cause of death in young girls a few years ago. Suicide is also the leading cause of death in young women in China and a variety of other countries. And of course, suicide is an archetypal mental health outcome in terms of it being a fatal consequence of a number of different mental health conditions. And it's obvious from this slide that mental health problems, therefore, are also a leading cause of death in many parts of the developing world. But we need to go beyond the impact on health outcomes, specifically when one considers the consequences of mental and substance use disorders. One of the problems with the global burden of disease way of estimating the impact of health conditions is that it focuses largely on individual function and survival. And I think any of you who work with mental health problems will know immediately is that in fact often the gravest consequences of mental health problems in fact go beyond the individual. They go the impact on families, and indeed in the case of conduct disorders and substance use disorders, the impact on wider society and the criminal justice system are quite enormous. There's also the impact on educational attainment. We often think of education, for example, as a very important determinant of health. But we don't often think of the consequences on education of health problems. And of all children's health problems, it could be argued that mental and developmental disorders have the most profound adverse effects in terms of educational attainment. Certainly in India, for example, one of the leading factors that is responsible for school dropout or poor educational attainment is to do with learning disabilities and a variety of other developmental disorders. Impaired economic inclusion, antisocial and criminal behaviors, particularly linked to substance use and conduct disorders in young boys. And of course, increasingly these days, you will see a growing litany of stories of young men and young women who have been attracted by extremely radical and criminal worldviews, mainly hate-based worldviews, and at least some of these young men and women also have had developmental trajectories that speak towards mental health problems. Indeed, if you look at the larger consequences of mental health problems beyond simply looking at health outcomes, it would be fair really to link youth well-being, young people's well-being and mental health to the broader concept of capabilities. This is something that attracts me greatly in terms of getting more traction on mental health of children and young people, going beyond a narrow health paradigm. Because capabilities, of course, is a much broader construct, which is widely promoted by economists such as Amartya Sen. And if you look at this definition, it's very obvious that all the consequences of mental health problems that I described in the earlier slide clearly would have an impact on the abilities and capabilities of young people to not only enjoy healthy lives themselves, but to contribute effectively to the communities in which they live. But beyond, I think, the capabilities argument, I want to also draw your attention to something that you probably never see in Canada or indeed in any other high-income country, which is the profound abuse of human rights of children affected by mental and particularly developmental disorders. And by human rights, I don't only refer to the fundamental right to care, but to the right to a life with dignity. Here you see an image from a so-called hospital ward for children with developmental disabilities taken in South Asia. And actually, I could show you a large number of images like these, which are just simply harrowing and heart-rending. But this is actually the kind of care that many children, particularly with more profound forms of developmental disabilities, continue to receive. It's essentially custodial care, in which, of course, the quality of care is abysmal, and these children will have a very high premature mortality. I remember many years ago, I'd led for the World Health Organization a survey of mental, neurological, and substance use conditions in Mozambique. And one of the most stark findings we had is that we found not a single adult with a developmental disability in these rural and urban communities in Mozambique. And of course, it was stark because I had just finished training in Britain, where you see entire services developed for adults with various forms of developmental disabilities. And when you'd ask community leaders, where are the adults here with Down syndrome, with autism, with mental retardation or intellectual disability, as we call it now, where are these kids? Where are the adults? I said, well, no, they all die. They die because really, at the end of the day, for families with many kids, these are the children whom they can least afford to look after. So in summary, mental and substance use disorders and injuries of the whole range of injuries are the leading causes of death and disability, particularly in adolescence. And it's important to stress once again that this is not only a high-income country pattern. This is seen in all countries, particularly so, one has to also admit, a middle-income country pattern. But as countries make the transition economically, we will see a proportionate rise in all countries of the world. Secondly, high-risk behaviors, those particularly linked to interpersonal violence, substance use, and risky sexual behaviors are the leading risk factors for the burden of disease in adolescence in particular. And in a very brief way, I've also tried to illustrate how these conditions have an impact that goes way beyond narrow health-defined metrics and affects their economic, educational, and social outcomes in profound ways. And I want to turn to the second part of my talk, which is to really look at the response that public healthcare systems in the global context have made towards addressing mental disorders. We traditionally think of two kinds of barriers when we think about improving access to care. The first kind of barrier is simply looking at the availability of the interventions and the human resources to deliver those interventions. And here on this slide, you can see what a dramatic inequity there is in the distribution of global child mental health resources. In short, and you will probably come across this 90-10% 90-10 inequity in a variety of different health indicators, and you can certainly apply that to child mental health and more broadly mental health resources in the global context. 90% of all mental health resources, whether you consider mental health resources in terms of mental health professionals, beds, dollars spent, etc., are really allocated in countries where only about 10% of the world's children actually live. There's one systematic study that actually looked more concretely at the availability and distribution of child mental health resources. You can see it covered a handful of countries across the world. And on this slide, you can see some of the headline findings from that report. Children and adolescents in most of these countries would occupy, would contribute to about 30 to 45% of the population, and yet really account for about 10% of the outpatient population and a very small fraction of the inpatient beds in mental health facilities. Training for mental health professionals typically is extremely limited in the area of child and adolescent mental health. The vast majority of mental health professionals in the global context will be adult mental health professionals. And the whole notion of an interdisciplinary way of working for children, which is so essential particularly for developmental disabilities, but also for mental health problems in adolescence, is completely absent. So the specialist provision of mental health care, by and large, in most parts of the world, is now done through adult psychiatrists, adult mental health professionals, and or by pediatricians, neither of whom have actually received systematic competency-based training in the diagnosis and management of child mental health problems. If I had to really make a guesstimate, we don't actually know from any primary empirical data what is the coverage of evidence-based interventions in the global context. But if I had to look at the country that I know best and work in very closely in India, and I had to ask the question, for example, to what is the coverage of, let's say, psychological therapies for adolescents with mood, anxiety, or substance use disorders, I would say the coverage is about 1% or less, and that is in the urban areas. Similarly, if I had to ask at the other end of the age spectrum in very young children with autism, what is the coverage of interventions that are specifically targeting autism impairments in the community? Once again, I would guess, and I'd probably be quite accurate in saying that only about 1% or less of children have access to those interventions. So in part, one of the major barriers, a very big barrier to improving access to evidence-based interventions, is simply the lack of specialized human resources and other kinds of resources such as beds, hospitals, to actually provide these interventions. But I think it would be unfair to simply say the problem is we don't have enough professionals. I think one has to also acknowledge that there are very significant demand-side barriers. Indeed, there is a very low demand for child mental health care services. We've been doing a lot of work in a part of India where I've been based for about 2 decades to really examine the sorts of attitudes that parents with children who have had a diagnosis of, say, for example, ADHD or autism have about their child's condition. So, for example, asking them questions, when did you first notice that there was a difficulty that your child had? At what point, or what did you do after you noticed this? When did you finally choose to seek care, help from our service, and why? And typically you will find that there are lag periods of up to 10 years between the time that a parent has first noticed a problem with their child. Usually it's the mother who notices the problem first, and when the collective family decision is made to actually bring that child to a mental health service. And of course, in part, that is because of the stigma attached to mental health problems, but also in part it's got to do with a very different understanding of what these problems are. So, for example, in the case of autism, the delayed language development or the absent language development or the loss of language is often actually conceptualized as something that runs in families, which of course is not untrue. However, it is also then interpreted as being something that will recover naturally as the child will grow older. Similarly, ADHD, for example, is almost never conceptualized as a mental health problem, but very frequently conceptualized as a learning problem, which of course is also partly true because these often tend to coexist. But the problem, of course, is that therefore there is very little demand for clinical services that target the mental or developmental disorder. Now, another kind of response is to look at the science output. And of course, in this particular field, the questions we're asking in global health are not so much about what interventions work, although that's important to know, but really how do you deliver these interventions in the real world. And therefore, key kinds of science questions that are important are those that come from implementation science. My colleagues, Christian Keeling and Luis Rode from Brazil, did a review to really look at the academic output in child and adolescent mental health over a 10-year period. And the first thing they noticed in this slide was a dramatic increase in the number of primary research articles on this particular subject coming from a very large number of countries. But then they really wanted to drill down and say, just as you had an inequity in terms of the availability of human and other resources, what was the actual distribution of this research output according to countries of the world? And this is what they found. About 10%, just like the 1090 gap, once again you see a 1090 gap here in terms of research evidence, only 10% of the science in terms of publications on child and adolescent mental health came from the low and middle income world. And if you look at that 10% in more detail, on the right-hand side of this pie chart, you'll see that actually only about 1% came from low, middle income and low income countries. In fact, from 42 countries in the world where about 75 million children live, there was not a single empirical piece of evidence on any aspect of child and adolescent mental health in this 10-year period. So we have another huge problem in terms of knowledge, because it has to be said that with all health problems, but particularly even more so with child and adolescent mental health problems, which are so often contextually determined, the absence of contextually appropriate evidence often acts as a barrier to improving access to care. So, the summary of this second part is due to a combination of demand and supply constraints, probably less than 5% of the mental health care needs of children affected by mental disorders are being addressed, and about 10% or less of the entire global output of child and adolescent mental health research comes from these countries, and therefore this knowledge gap is another big barrier. I want to finish now by thinking about a more positive spin, that is to say, what are the opportunities we have? And I want to start, first of all, by highlighting the tremendous opportunity we have through the new understandings of brain development from the earliest days of childhood all the way through into adolescence. Two especially new understandings. The first to do with the differential maturation of the brain that has extended our understanding of how dynamic brain development is way beyond middle childhood, which was the way, certainly when I was a medical student, I was taught. And secondly, of course, linked to this idea is the idea of brain plasticity, which also extends way into young adulthood and indeed even beyond, which of course allows us to now think about the impact of behavioral interventions in a very specific way in terms of the mechanisms through which these interventions might potentially affect basic brain function and then the ultimate mental health or developmental phenotypes that we see. The second important opportunity is the large evidence base of exactly these kinds of behavioral interventions. A range of interventions that was summarized here in the Lancet a few months ago as part of the Disease Control Priorities Network initiative on mental, neurological, and substance use disorders. I'm sure many of you working in global health will know about the DCP enterprise, which is really an enterprise that is aiming to generate evidence that is useful for policymakers to make informed decisions of which intervention should be scaled up. So here, from that paper, I've just excerpted the interventions that we recommended for child and adolescent mental and developmental disorders. And of course, in the DCP, for those of you at the back who may have difficulty seeing this slide, the DCP really organizes interventions according to where you might deliver them. And so you have population platforms, a good example of an intervention that emerged as a really great intervention to support our child protection laws. Community platforms, healthcare platforms from self-care, primary healthcare, and first-level hospitals. But one way that I would really like to summarize this group of interventions and really refer back again to the neurodevelopmental knowledge that we now have is to think across the life course of interventions that have two different objectives. Firstly, interventions that are promoting healthy brain development from the earliest days. So, for example, cognitive stimulation in the first 1,000 days, appropriate nutritional interventions for brain development. Into childhood and adolescence, building social and emotional competencies, for example, through life skills training. And finally, improving access to psychological therapies, which of course have now also been shown to directly influence brain function as a part of their pathway to recovery. And of course, twinning with that is to promote nurturing and less toxic environments for children and young people. And here are some examples of evidence-based interventions that seek to achieve that, changing the home environment through parenting, changing the school environment through working with whole school systems, changing the neighborhood environment through building social networks, and of course, changing the macro environment of children and young people's lives, for example, by protecting them from unhealthy products and lifestyles. The guiding principles for scaling up really must be focusing on high burden conditions, cost-effective interventions, integrating through established platforms of care, and delivery by non-specialized workers. Of course, an innovation that has been championed by global child health in so many other areas of child health, such as childhood nutrition and survival. And we're blessed. We may not have enough child mental health professionals or developmental pediatricians, but we are blessed by the number of human resources that are concerned about the well-being of children in all parts of the world. And perhaps the most important resource of all is, of course, the parent of the child himself or herself and community health workers. And I want to now just give you I have a few minutes left, I just will spin through quite quickly an example of how we have used these principles to improve the quality of care for children affected by autism in South Asia, a partnership. Very rarely do India and Pakistan ever work together, and this is a terrific example of actually such a collaboration that has been very, very productive. What we did in this particular initiative, which is actually a 7-year initiative supported by Autism Speaks, was to adapt an evidence-based intervention for delivery by non-specialized workers and to evaluate that intervention in a rural and urban community in India and Pakistan. We chose an intervention built on very strong global evidence, the Pact intervention that has been developed and evaluated in the UK and has now been recommended. Of course, Pact is just a brand, but what it's really doing is targeting social communication as the core mediator towards improvement in the overall autism phenotype. Not only is Pact evidence-based, but I can tell you in advance now that the 6-year follow-up of these children will soon appear in the Lancet from the UK, and is actually the first evidence-based intervention for autism that has been able to demonstrate change in the actual phenotype 6 years on after the intervention was delivered. We liked the intervention because not only was it evidence-based, but it was low intensity and did not require a very highly trained professional to deliver the intervention. Over a space of 2 years, my colleagues and I in India and Pakistan adapted this intervention to create a South Asian version, which is called PASS. And the key features really that differed from the UK Pact intervention are shown on this slide. Well, some of the similarities and some of the differences. The main difference was that, of course, it's no longer being delivered by a child development professional, but by a community health worker. It is not being delivered in a hospital, but it's being delivered directly in the parent's home. But one of the things that we were a little surprised by, which we had earlier felt a little concerned about the applicability or the generalizability of the intervention, was this issue of video aided. And I think one of the great discoveries for us in the formative work was how well parents in these low literacy populations took to video-based learning on how they should actually deliver the intervention at home. We've published the results recently, a few months ago, and the most important finding was that we replicated the same findings from the UK, really demonstrating, first of all, how the theory of how these interventions work in the UK were generalizable to these very different cultural contexts of India and Pakistan, also confirming in some ways really the way we understand the basic pathology of autism, but importantly also demonstrated that some of the things that most people would imagine would not translate to non-Western settings, for example, the use of video-based learning for parents actually did generalize very well. There were high degrees of acceptability, high degrees of fidelity for the non-specialized worker, and ultimately very good effectiveness. So therefore, where are we now with this evidence? The good news in South Asia is now we have screening tools that have been validated for the detection of neurodevelopmental disabilities in young children, including autism. We have a national program in India, at least, which is advocating the use of frontline workers to actually deliver interventions for developmental disorders. And so this particular intervention package now has a ready audience in terms of human resources to deliver it. And there's an advocacy network that's been formed across the 6 regions of South Asia, involving political leaders, consumers, and professionals to advocate for improved access to care for mental health problems. So I want to conclude really by leaving you with these key messages. More than 80, in fact probably 90% of the world's children and adolescents live in the global south, low and middle income countries, predominantly in sub-Saharan Africa and South Asia. The large burden of mental disorder that we see here, and which will continue to grow as these countries make the epidemiological transition, really has to be aligned with a coordinated response in the health sector to address the mental health needs of these children. And in my view, what we need to do is to go beyond the siloed approach that we've traditionally taken that has focused on disease phenotypes and think of a life course approach from the earliest days of childhood if we are going to be able to address the burden in terms of prevention as well as reducing the incidence of these conditions and the longer term adverse outcomes that these conditions have on the lives of children and their families. Here are a few of the resources, the reading resources. I will leave these slides with the center here so you can look at some of the publications on which this particular lecture was based. Most of these are high-level reviews that really bring together and synthesize the evidence around children and adolescents' mental health in the global health context. I want to also acknowledge the many funders who've directly funded the work that I do in India and Pakistan. And finish off really by acknowledging a small NGO that I've been working with for the last 2 decades, which is called Sangat, which actually celebrates its 20th anniversary this year, and through which much of the primary research that I have done in this sector has been implemented. And I think I'm sure as Zulfi will also testify through his own work in Pakistan, it's quite remarkable how small organizations with very limited resources are actually able to implement such innovative solutions in these difficult environments. Thank you.
That was predictably fabulous. Thank you. I've heard you say before, and I'm interested in seeing if this is something that you would still say, that unlike in high-income countries where there's an assumption that suicide is a result of mental illness, that in low-income countries that is not always the case, or that assumption isn't true, and that suicide often has to do with just the helplessness of people's situations. And if you still think that's true, then what I'm wondering is, as somebody who's been accused of being a clinician activist, whether you think that activism around those issues should be in the hands of clinicians, or if we should be providing the information to young people who so desperately want to have meaning in their lives to be the activists who are fighting these things.
So first of all, I think that's a really important point. This is an observation that many have made, that suicide in developing countries, particularly in the adolescent age group, are not attributable to frank mental disorders, although we would all agree that you couldn't be in good mental health. It's an oxymoron, really. But whether you have a diagnosable mental disorder is, I think, what you're referring to. And therefore, the idea would be, in terms of interventions, to reduce this enormous, incredible burden of suicide. Yesterday, I was sitting with my colleague Prabhat Jha and looking at the latest results on suicide in India, and it's completely the same. 10 years, no change at all. And so that's why suicide, of course, is now the leading cause of death, because maternal mortality has fallen. And I think I would agree with you entirely that in this age group, a narrow biomedical psychiatric model is an insufficient one to explain the burden of suicide, and one has to think of a broader social understanding. So what might that be? I think I talk about this a lot when I'm focusing on suicide, is the aspirational gap for young people. And what is that aspirational gap in India today is the empowerment of young women in particular, because that's the other peculiar thing in Asia, is that young women's suicide rates actually are higher than young men's suicide rates, which is not the same pattern in Canada. And so what is the obvious corollary of that is that for young women, the opportunities that they are entitled to and now expect are actually not being met by a very conservative social milieu. One of the curious things about suicide of young people in India is not only the female excess, but it's also more common in the educated young women and in the more developed states of India. It's the only health indicator that actually is more common in South India than it is in North India. And so one way of looking at this at an ecological level is that these are the states where young women are expecting and demanding greater freedoms. But those freedoms are not actually being made available by society. Very provocative hypothesis, but it's one way of trying to understand this epidemic.
So Vikram, let me ask you a question that I've struggled with and don't have the answers for, which is the last decade and a half has been devoted to reducing mortality. And we have an unfinished agenda, although we have made progress. And now, with the rightful recognition of the enormity of things that are beyond survival, related to mental health, related to long-term outcomes, how do you see the world striking a balance between the two? Particularly when it has to then find a balance with the same service delivery channels. So community health workers are an example. There are only 24 hours in a day and only 2 hands. So how should we approach this from the global public responsibility and the platforms that we visit?
So I think this is, I don't think there's an easy answer to that question. It is a complex one. But here are a few important things that I often put on my wish list. The first is that I think we should stop thinking of mental health and developmental problems purely as a medical problem. I think if we simply adopt paradigms that come, say, from childhood diarrheal disorders, which has, we've seen some tremendous traction and success there, no question about that. But of course, the interventions are highly technological in many respects. They're very individualized interventions. And I think as long as we adopt those models and imagine that there will be a corollary for mental health and development problems, I think we will hit a wall. There are no technical fixes in the same sort of way as we have for infectious diseases for these far more complex conditions that involve an interaction between brain development and so many different social factors. So the implication for that is that we have to start thinking about prevention in a very different way by engaging with other sectors in the government. A key sector, of course, for that would be education. It always amazes me that we do not see education as a very important opportunity for promoting child mental health and adolescent mental health. Another key sector is actually the whole system in India, for example, of creches that the government supports through the Ministry of Women and Child Development. Again, this isn't seen so much as a platform at the moment for prevention of child development mental health problems, as much as just simply a place for children to be kept while their mothers are working. But it is such an enormous opportunity for us to engage that particular sector. So really looking beyond the health sector. The second important challenge in our field is that, as you'll have noticed, one kind of intervention are those interventions that promote nurturing environments. And a very key nurturing environment is the one at home, especially for younger children. And it is very, very difficult at the moment within health policy to step into homes and see that as the mandate of the state. It is the, that is a sacrosanct space where parents, working with parents towards parenting intervention, which I was assume in Canada is not part of the course, is completely unthinkable in most parts of the developing world, but it can change. We do work with parents already in very early childhood for positive parenting practices to do with nutrition, for example, but to go beyond that and to start thinking, for example, of positive disciplinary practices, practices to do with creating positive environments for young children is, in my view, potentially a very important next step in the field.
Thank you.
Joanna Henderson, Director of the McCain Center for Child, Youth, and Family Mental Health at the Center for Addiction and Mental Health. So I wanted to go back to the first question and also what you were just commenting on, and ask you to comment on trauma, because I thought where you might go in thinking about the suicide rates amongst young women is to think about exposure to interpersonal trauma, and you sort of started to go in that direction, I think, in your last comments, and I just wondered if you could say a little bit more about the importance of addressing trauma and exposure to trauma as part of an overall prevention initiative.
Yeah, well, absolutely. For me, I wasn't explicit, but of course, violence is the ultimate end product of the denial of freedom. But I think violence is only the tip of the iceberg. The denial of freedom actually is a much bigger iceberg. So, for example, the denial of the right to choose who you actually want to live with may not. It is, in my view, is a kind of violence, but it's not exactly seen as violence in the trauma sense. It's not physical or sexual violence, but it's a kind of psychological violence. That is far more common than physical violence, but I do see this as part of the same continuum. So yes, trauma is very important, but in the broader context of the kind of gendered disadvantages that women face. I have to say, gender disadvantages are also exposed by men. But they often express themselves in very different ways. So for example, for young men in many parts of the world, the ability to express your emotional needs is denied because of your masculinity. And this then often means you translate your emotional distress into a variety of unhealthy behaviors, typically substance use or violence. So I think there are unmet needs for both young women and young men, often very gendered. But clearly, the denial of opportunities is much greater for young women than it is for young men by a very long, by a significant amount in most parts of India, certainly. And I often bring up the example of young men. The pressure on young men isn't so much who you choose to live with, although they also have the same prescriptions, but actually what work you do. So you will see a lot of pressure on young Indian boys on certain kinds of occupational choices, and there's a very sort of pressured environment for them in order to perform in a certain level education as well. And you also see this in many other Asian countries. Actually, it's not just true of India.
Dr. Patel, we talked before this lecture, but it may be somewhat surprising that we have communities in Ontario, our home province, that are extremely isolated, and providing mental health services has been and continues to be a challenge in our own province. As I discussed with you earlier, we have, I think, a fairly sophisticated and successful telehealth services for providing both direct client care as well as education of primary care providers around mental health issues in situations where it is difficult for the patient or their family to come to our institution. So I have two questions, really. One is, could you talk a bit more about video-based learning? You mentioned it very briefly. And the second is, in India, how are they dealing with the challenges of providing mental health services in situations where A, there are not enough health professionals to provide the services, and B, the individuals and communities are very isolated? Is there any type of reverse innovation that we can be learning from the situation in India?
Well, thank you actually for asking that question, because I'm as we were talking earlier, I'm a huge believer in the power of technology, information technology, to leapfrog what can be incredibly huge barriers towards improving access to care. The first thing I want to say very clearly is that the idea that the solution lies in simply training more of us is not a viable one. I think for many people in the medical world, the idea is simply that whatever we're doing now is a kind of stopgap measure until we have enough child development and mental health professionals in the global context. This is not going to happen in anyone's lifetime. So I think we need to abandon the idea completely that that is the primary goal. The primary goal is to improve quality and access to care now. And how do we achieve that with the resources we have? And it seems to me that technology offers really remarkable opportunities. So telemedicine is one example where you literally, I think as you do in Canada, you essentially bring the specialist professional into the home or clinic of a remote and rural area by simply having a technology-enabled communication. But I would go beyond that, because that also still relies on a professional. And even in that context still, there are very few professionals. Consider, for example, let me give you an example of exactly what we're talking about, what numbers. India has 1.2 billion people. If I include the whole of South Asia, it's 1.5 billion people, of whom about 40% would be under the age of 19. So you can do the maths, that's nearly 500 million children and adolescents. The whole region of South Asia has less than 1,000 child mental health qualified professionals. The whole of South Asia has less than 1,000. It's probably more in Ontario than there is in the whole of South Asia. And by child mental health professionals, I'm specifically referring to developmental pediatricians, child psychiatrists, and child clinical psychologists, about 1,000. Keep that in mind. And you can begin to see that it's virtually impossible to even imagine a service that is going to be led by these professionals. These professionals have to play roles of organizing, leading, showing leadership on how you can, in fact, decentralize care using frontline workers. And one way is to use technology for training of these workers. So, for example, using technology-enabled platforms for learning treatments, for supervision using social networks, for delivery of interventions such as the video-based learning through apps that can be downloaded onto phones. And this may all sound future ideas, but actually they're already happening in many parts of the developing world. And the other important, exciting thing of technology is for diagnosis. So we have a new program of work that we are launching, which is using the same mobile health tablet platforms for assessing children's cognitive function by using eye tracking, for example, using gaming interfaces, etc. And I think certainly when that is more advanced, I would imagine that we would have ultimately a mobile platform for community health workers to detect, to provide first-level interventions, and to support families through self-care modules to help their children with developmental and mental health problems. It's still ahead in the future, but there's no question that that is the direction of travel that this field has to take.
So, ladies and gentlemen, we've had a tour de force. You've heard from a remarkable individual that has single-handedly and with some dedicated colleagues changed this field from a situation where it was an empty glass to a glass quarter or less than half full, to now very hopeful and promising interventions at a level of population platforms that give us hope that something can be done. So it isn't a doom and gloom scenario. It's an area where, although there are huge challenges, both in terms of numbers, measurements, things that can overwhelm you, and also the typology of things that we are looking at range from insurmountable, difficult issues like autism to preventable and manageable disorders that can be addressed with technology and expertise that we have today. So, Vikram, I wanted to thank you for spending time with us. And Vikram will be available to us in the reception that's outside. I did want to finish with a few observations that as we look at the world today and the challenges that beface us, mental health and related disorders, and maybe we need to come up with a different terminology for this, maybe developmental disorders, are going to emerge as the dominant issue. And that's one of the reasons why in the global strategy for women and children, so-called Every Woman, Every Child strategy, we have developed this concept of linking survival with thrival and also with transformation. So transforming communities and families so that they have the ability to not only recognize but also be part of the solution here. This is very close to my own heart because although I come from a survival background, I have come to realize that it isn't enough. the world as we see today as pediatricians is a very complex place, and it's a painful place. Within the last few days, you've seen images of children traumatized in the conflict of Syria, to the realization that today this is virtually the norm in about 40% of the population so affected, where the burden of maternal child morbidity and mortality clusters. We've also seen how a child was the perpetrator of a suicide bombing in Turkey that killed so many. It was a child, a 15-year-old, and how another would-be suicide bomber at the age of 15 was disarmed just a couple of days ago. These are victims of conflict. These are victims of trauma and the environment that they live in. And therefore, as public health professionals and pediatricians, it's a moral obligation for all of us, irrespective of disciplines, to become engaged as advocates and to become engaged as public health individuals who can influence global policy and the interface of what Vikram mentioned: child protection, child rights, human rights, child health, and public policy. So Vikram, once again, thank you very much for your time, and may I invite you for refreshments outside.